Hello, everyone. I'm Dr. Carmen Pugliafito. I'm here today with one of our retina synthesis superstars, Dr. Roger Goldberg of Bay Area Retina Associates, headquartered in Walnut Creek, California. Welcome back to Retina Synthesis, Roger.
Great to be back, Carmen. Thanks for having me on.
You recently reported on some interesting data from the use of 8 milligrams Aflibercept in diabetic macular edema, looking at drying effect and central macular thickness. Can you tell us a little bit about 8 milligram Aflibercept and this study, the PHOTON study?
Sure. So the PHOTON study was the pivotal trial that led to the FDA approval of 8 milligram Aflibercept for the treatment of diabetic macular edema. And we've now seen the top line results presented, both the 1 year and now the 2 year data showing the efficacy and safety of 8 milligram Aflibercept dosed either every 12 or 16 weeks in comparison to 2 milligram Aflibercept. We've actually seen the data now for both AMD and DME. This was an analysis, a post hoc analysis of looking at, to really try to better understand the durability of 8 milligram Aflibercept in diabetic macular edema, and looking at the patients by kind of their quartile of fluid, by their baseline central retinal thickness. Because when we look at these average central retinal thickness curves, well, that's the average of hundreds of patients, and some of those patients enter the trial with a little bit of fluid, and some enter, frankly, with quite a lot of fluid. And I think when these next generation medicines get introduced, the patient population, in many respects, that we're most interested in treating, at least initially, are those patients who are kind of stuck at a monthly treatment interval, maybe are doing well, but you can't extend the interval at all. And so I think this was a pretty interesting post hoc analysis, and it really, I think, highlights the durability advantage of 8 milligram Aflibercept versus 2 milligram Aflibercept in diabetic macular edema.
So how was the study designed?
Sure. So the overall study, of course, was patients were randomized to either 2 milligrams every 8 weeks, 8 milligrams every 12, or 8 milligrams every 16 weeks after 3 monthly loading doses. The 2 milligram Aflibercept got 5 monthly loading doses per its registration trials, Vivid and Vista, long ago. And we know kind of when we look at the overall population, it was non-inferior in terms of visual acuity. The visual acuity curves largely overlap. And the central retinal thickness curves, when you take the total population of patients, which was over 600 patients, nearly 700 patients, those central retinal thickness curve overlaps as well. But we know that the average patient doesn't just walk into your clinic. Some of those patients, if you broke it out by baseline central retinal thickness, we broke them out into quartiles. Quartile 1 had just a little bit of fluid. Their central retinal thickness was less than 360 microns. Quartile 2 was 360 to 430 microns. Quartile 3 was 431 to 528 microns. And quartile 4, those most swollen or edematous retinas, had to have at least 528 microns central retinal thickness in order to be eligible to be in that fourth quartile. And then we look to see kind of how does 8 milligram versus 2 milligram of Aflibercept do when you look at mean change in BCVA and central retinal thickness, and who were able to maintain either that assigned dosing every 12 or every 16 weeks. And so if you look closer in at quartile 4, on average, those patients had well over 600 micron central retinal thickness. And interestingly, kind of quartiles 1 and quartiles 2, where there was very little, or less edema at the outset, we really see a very tight and overlapping central retinal thickness curve. In quartiles 3, and then especially in quartile 4, we start to see more of that sawtooth pattern, even in the 2 milligram Aflibercept treated eyes who are treated every 8 weeks. We see that because these are the hardest to treat eyes, and we know that the fluid reaccumulates more quickly in those eyes. So what we did is we said, let's dig in a little bit more closely and see what happens after those monthly loading doses. So the 8 milligram aflibercept eyes get their 3 monthly loading doses, and then 4 weeks later, they're observed, they're not treated. Actually, the central retinal thickness continues to go down about another 20 microns. And when you look 8 weeks after their last loading dose, the central retinal thickness is only 5 microns greater than it was after the monthly loading doses ended. So we see just 5 microns, basically stability 8 weeks after the last loading dose. When you look then at the 2 milligram of aflibercept eyes in the same difficult to treat population, quartile 4, here we see good drying effect with the monthly loading doses. 4 weeks later, we don't see any further reduction in central retinal thickness. It tends to remain stable. But then 8 weeks after the last loading dose, we see 55 microns of fluid reaccumulate versus just 5 microns of fluid in the 8 milligram eyes. So to me, that really suggests in these most difficult to treat eyes, we're seeing much better durability with 8 milligram of aflibercept versus 2 milligram of aflibercept. And I think that's very reassuring. Not surprisingly, when you look at kind of how many patients in the 8 milligram arms were able to maintain their assigned dosing, either every 12 or 16 weeks, we do see a slight reduction versus the other quartiles, but still well over 3/4 of patients in quartile 4 were able to maintain their assigned interval of every 12 or 16 weeks.
So what explains the durability?
What explains the durability? Well, I think it's the fact that, we're injecting here 4 times the dose of aflibercept. And when you look back at like animal models, rabbit eyes where that had kind of animal models of vascular leakage, when you quadrupled the dose, you actually saw a delay in the time to leakage, resumption. Anyway, it went from about 2 to 3 weeks out to 7 weeks. So we saw a significant expansion in the amount of time that you could suppress vascular leakage in the animal models. Frankly, it was that data that led to the development of 8 milligram of aflibercept. And now we're seeing a very similar effect in human eyes, at least in those most swollen diabetic macular edema eyes.
So what is the take-home message to the clinician faced with a patient with severe retinal thickening?
Yeah, I think it really suggests that I think, frankly, loading these patients monthly, they tend to do quite well, whether you're loading them with 2 milligram or 8 milligram of aflibercept. But those are the types of patients where, at 4 weeks after a 2 milligram of aflibercept, they look good, but if you try to go to 8 weeks, they've actually reaccumulated quite a lot of fluid. If you switch those patients to 8 milligram of aflibercept, it seems that you're going to be able to suppress the reaccumulation of that fluid at least out to 8 weeks, which I think is helpful clinically because we know that 8 milligram of aflibercept is approved for 3 monthly loading doses followed by every 8 to 16 week interval. So being able to get patients out to at least an 8-week interval in those difficult to treat eyes, I think is important clinically, just in how we're frankly allowed by insurance companies now to use 8 milligram of aflibercept based on its FDA label.
Mm-hmm. Have you used 8 milligram aflibercept in your own clinical practice?
I have, yeah. I've started to introduce it both in AMD and in DME, and testing it actually kind of like a variety of different patient types. Obviously testing it in the kind of most difficult to treat eyes, but also testing it in some treatment naive eyes. And then actually looking at that population that's kind of, maybe I'll call them like the 8-weekers on Eylea, on 2 milligram of aflibercept, and saying, hey, can I get those patients out, to 12 weeks, for example, with aflibercept? And so I'm still getting kind of that early feedback from it. Obviously, to kind of extend a patient out to those types of intervals, it takes a little bit of time. But so far what I'm seeing is it's a highly effective drug.
Do you think that eventually 8 milligram aflibercept will replace 2 milligram aflibercept as the main armamentarium?
I think, here's what I'll tell you. I think most of us believe that Avastin is the weakest of the anti-VEGF agents that we use, and yet it maintains, a significant market share because of its cost effectiveness. So I think 8 milligram of aflibercept is probably a better drug than 2 milligram of aflibercept, but 2 milligram of aflibercept is going off patent. We're going to have a whole host of biosimilars available. And so I think there might be some dynamics that help kind of 2 milligram of aflibercept maintain some market share, just like Avastin has maintained some market share, even though we don't necessarily perceive it to be the best agent out there.
What's the next step in looking at DME and 8 milligram aflibercept?
Well, obviously there's the Photon study, which is the pivotal trial data. But I think kind of the most helpful thing ultimately is going to be looking at the real world data in terms of the uptake of 8 milligram of aflibercept. And just like when faricimab launched, soon thereafter, we got lots of great real world data, which is, how is the drug actually being used and performing kind of in our actual patients and not clinical trial patients. So I'm excited to kind of see these massive data sets, whether it's through the IRIS registry or through kind of, private efforts, kind of like Truckee was, to kind of look and see how 8 milligrams is doing versus 2 milligrams, both in AMD and in DME.
So when you've got a patient with severe diabetic macular edema, 8 milligram aflibercept might be a reasonable choice.
I think it's a reasonable choice for sure.
Thanks so much for your help today on retina synthesis.
All right, Carmen, great to be back here on retina synthesis.